Okay, my name is Brenda Banwell. I'm the Chief of Neurology and the co-director of the Neuroscience Center at the Children's Hospital of Philadelphia and a professor of neurology and pediatrics at the University of Pennsylvania. I chose to highlight the journey that we've all been on over the last 20 years in terms of pediatric onset MS. So first thing I want to highlight is that MS does occur in children, which was not actually fully understood 20 years ago. Second, that MS is an age-span disease. So children have relapsing or remitting MS, and it is biologically, genetically, phenotypically, at least in terms of the typical type of relapses, generally very, very similar to adult onset MS, if not exactly the same. Pediatric onset MS occurs, however, in the context of a child, and so there is a particularly negative effect on cognitive development and academics, which one would expect. The brain is still developing. Children haven't acquired all of their academic building blocks yet, and so having an inflammatory disease in the brain during that window of development has an effect. And we are hoping that higher effective therapies will reduce that negative effect, but it is a very real part of pediatric onset MS. The next thing that we highlighted as a community of people studying pediatric onset MS is that we can measure the effect of pediatric MS, at least quantitatively, on the brain and brain volume. And what we show is that even as soon as you measure it, first attack, the brain volume is already below what it should be for boys and girls of the same age, which suggests that that disease process didn't just begin when we met the child having their first event. It started way before that. How far before, we can of course not know. But Dr. McCanney and others have shown, in fact, that radiographically isolated syndrome, or the finding on a brain MRI, features that look like multiple sclerosis in someone who was perhaps had an MRI because they have headache, actually happens in children too. So early onset MS and even the prodrome or the preclinical phase of MS is a real component of pediatric disease as well. I think the next thing that is important to know is that the brain volume in children with MS is not only low when the disease starts, but the brain doesn't grow normally in children, so they don't reach their age-expected maximal brain volume. And then in teenage years, the brain volume starts to go down. So that, together with all of the impact on cognition, really motivates us to think hard about how we should treat children with MS. And just like in almost every pediatric situation, clinical trials for children fall way behind clinical trials in adults. They start much later, they're harder to complete, thankfully because pediatric MS is rare, but that still means that children living with MS do not gain access to highly effective new therapies at the same point as adults do. It takes years and years longer. Given that pediatric MS is a highly inflammatory disease with high relapse rates and a lot of T2 lesion burden, the imperative to get these highly effective therapies to our patients is extremely high and urgent. So we, the community, have completed a variety of clinical trials. The Paradigms trial perhaps being illustrative of some key points. First of all, it was a large double-blind, double-dummy clinical trial, which is not easy to do. It involved multiple sites in multiple countries, took a lot longer to complete than originally planned, in part because there's a learning curve with how to engage pediatric onset MS families in clinical trials. But the results were clear. Fingolimod was superior to interferon beta 1A on all measures. The patients treated with Fingolimod had far fewer relapses and far fewer days of hospitalization, which is a pivotal metric when you're a child and you're supposed to be in school. And of course, there was also a favorable effect on MRI. So fewer new lesions, and there was a significant reduction in the rate of brain volume loss in children treated with Fingolimod compared to interferon 1A. So those are really important. Those are the measures that we know correlate with poor outcome and that we worry about being predictive of long-term outcome. So it was promising to see that the drug worked on the early measures and provided some promise that it might mitigate the longer-term effects, and the extension phase is ongoing. So I think that was an important learning process. And then finally, moving into the next stage, there are multiple trials that are completing or just completed of other agents and more on the way. So my hope for the field is that 5 years from now, we'll be talking about a long list of treatment choices. And our next challenge will then be to predict or identify which choice is the best fit for a given child, just like it is in adults. So we've got lots still to do. Even though we've done a lot in 20 years, there's a great deal more that we need to do.